I'm Paul DeChant, and I'm extremely excited to be here today because we have a fantastic panel of experts to talk about this big challenge of clinician burnout. I personally have been a family physician for 25 years, had 30 years of practice management experience, and now do consulting. And shameless plug, I actually wrote a book about preventing physician burnout, and they've asked us to do a signing after this session. So if you want to come and have a book signed, that's there. But there's so much more that I can learn about this from our panel, and that's why I'm excited to be with them today. The people we've got is Dr. Steve Strongwater, and Steve is the CEO and president of Atrius Health, an 800-physician group here in the Boston area. He's also worked in leadership roles in multiple other healthcare organizations as well, so he comes with a wealth of knowledge around this, and at Atrius, you're doing some really exciting work specifically about addressing burnout for the physicians and the staff. Second, we have Cinda Rushton, and Cinda is an international expert in nursing ethics, a professor of nursing and pediatrics, and the Anne and George L. Bunting Professor of Clinical Ethics at the Berman Institute for Bioethics and Johns Hopkins University. So, excellent, a new perspective that I don't often get exposed to, so I'm very excited to hear what Cinda has to say. And lastly, and certainly not least, we have Laura Burke, and Laura is a practicing ER physician at the Beth Israel Deaconess Hospital, also and works with the DeChant Harvard School of Public Health in the Department of Health Policy and Management. And she was deeply involved in a recent publication that's come out with guidelines describing the crisis of burnout, which she'll be talking about as well.
Thank you.
So we're really fortunate. The unfortunate thing is we have 75 minutes total to talk about this, and we want to have a lot of audience participation. So we're going to restrict each of the panelists to 12 minutes to talk about their area of interest, and that'll give us a good half hour to share our thoughts. The one challenge we'll have in that is so many people feel so passionate about this that commonly when we present, an audience member will have an impassioned story to tell that can take up most of the conversation time when we do the Q&A. So we adopted the motto that there's beauty in brevity. As you present your question, think about it. Feel free to share, but be focused, and then we'll have a chance to all answer as many questions as we possibly can as we get started. When I think about burnout and what I've seen happen over the last few years is a real change from focusing on the thought that the root cause of the problem is the clinical worker to realizing it's actually the clinical workplace. Professional fulfillment comes from our ability to have a deep connection to our patient and to have a truly meaningful healing interaction with that patient. And what we've come to realize is that so many things have impacted our clinical workplace now that make it so difficult to do that. And ultimately, it's that disconnect that's driving burnout, that inability, the dysfunction in the workplace, to the point where that's seriously becoming a toxic workplace. When we see healthcare providers, we see clinicians suffering from depression, substance abuse, marital dysfunction, and suicide, to think that where we practice is not toxic when those are some of the outcomes that are resulting from that is to miss a key point. So much of the work now is focusing on how do we improve the workplace, and there's multiple ways to go about that. And actually, without saying any more, I'd like to hand it over to Dr. Strongwater to lead us off.
Good morning, and Paul, thank you very much. It's a great book. I highly recommend it. I'm actually going to start off with a question, if I could. Can you raise your hand if you feel like you are personally experiencing burnout? Okay, thank you. I'm reminded of a quote that a single individual can be a tragedy. Something happens to a single individual. But when it happens to thousands or hundreds of people, that's a statistic. and it's not quite as real. So I want to actually start with a story about a real doc. I'm going to call her Sarah for her protecting her identity. I came to our practice, and it's just a physician practice, as it were. We take care of about 750,000 patients here in eastern Massachusetts. And I met with Sarah, and what she said was, I have to stop practicing primary care. And I have to do it because I am exhausted, I am feeling increasingly cynical and ineffective. And by the way, last year I cut down my FTE time from 0.8 to 0.6, and I still can't keep up with the work. And she left our practice, and she left the practice of medicine. That is a tragedy. She is and was an outstanding clinician, highly sought after, and it is a tragedy. And those three things, feeling cynical, emotionally exhausted, and ineffective, is the definition of burnout. Now, I'll share with you that over time, we have come to learn that there is a cost to losing Sarah, not just an emotional cost, but a financial cost. So the average cost per doc, as we've looked at it, is somewhere between $400,000 and $1 million. This was recently published in the Annals. It's costing the country $4.6 billion with a B dollars every year. Those funds could make a huge difference in the kind of work that we all do. So I really want to leave you with three important takeaways. The first is that this is really not a problem of whining. A lot of people who are in administrative roles, and I'm wearing the CEO hat, so I'm safe in saying this, I'm also a recovering hospital CEO, think that you doctors, you nurses, you nurse practitioners, you're just not tough. In the old days, people would just take care of it. And in truth, there's just more work to be done. The electronic medical record, as many of you have heard, has added innumerable hours to the work, and it's made work depersonalized and less meaningful. What we heard earlier today are stories about what's most meaningful, the personal connection to families. And so the first thing is it's a real problem. And until leadership recognizes that it is a real problem, fundamentally, not very much is going to change. So that's the first part. The second part is this is a detectable, measurable problem. It has, in the past, in my view, been a hint and hope problem. I learned about hint and hope from a nursing colleague. Basically, it goes something like, I hint this is a problem, and I hope you do something about it. And I hate living in the hint and hope world. So you can measure how you are doing. And we, in fact, in our practice, we measure this. We've come on the journey from asking 2 simple questions to using more formal surveys, Maslow, and now Stanford Well. Perhaps that will change. But you have to measure what you're doing. The third, I would say, takeaway is you actually can do something impactful. There is no silver bullet. It's not like you buy an app or you send your friends off to Canyon Ranch for a retreat. It's truly a multi-part approach to tackling so many problems. And what I'd love to share is Tate Schoenefeld's work from Stanford, who has actually put a nice package around how to think about burnout. And it's really 3 parts. Think of it as 3 equal parts of a circle. And that is a culture of wellness, personal resilience, and then a practice, efficiency of practice. Now, as you visualize that, the middle of that, if you get the balance right, is professional fulfillment. In truth, they're really not 3 equal parts. The most important part of that circle is practice efficiency, because what we have fundamentally done, I'm speaking mostly on the outpatient side, is we have made the work undoable. And we have asked people to be Herculean in their efforts, and it's through those extraordinary efforts that people are actually providing the kind of care and support that patients are seeking. What's happened to the docs in our practice, which is largely a primary care practice supported by specialists, is that our docs have what I would consider to be a version of post-traumatic stress. And that is because they are always on call. Sarah, when we went back and looked at her EPIC profile, was working between 14 and 16 hours a day. It's because she was working after work to close the My Health messages. Now, we live in mostly a capitated environment, and so if we can keep people out of the office and out of the hospital, that's a good thing from a financial perspective, but it comes at a price. And right now, more than half of our encounters are non-face-to-face. Who's doing those encounters? They're the really hard-working primary care docs, and they're doing them on nights and on weekends, and they've traded their personal lives for their professional lives. And the reason that Sarah would no longer put up with that, and literally took a pay cut to cut her FTE down, and then ultimately had to walk away, is because she had a young family. And she could no longer keep the balance in her life. Now, what can you do, or can you do something tomorrow that would have an impact at each of your locations? The most important thing I believe you have to do is to get the attention of the leadership, that is to say, the CEO and the board. Until the CEO and the board are held accountable for reducing burnout, nothing will happen. So all of my senior team is evaluated for their bonus pay and merit, of which they are about 30% at risk of their salary, on the basis of whether they can improve and reduce burnout across the practice. So when I talk to our leadership, they know we're serious about this, and we have made an extraordinary investment in people and in resources. In particular, the investment in leadership training, in cultural improvement through empathy training, and now, it's interesting, we heard Amy Edmonston, who, by the way, I'm like starstruck, in psychological safety. So we are on that path of firing on those three cylinders. As importantly, we have made sincere efforts to reduce the number of electronic medical clicks that the primary care docs experience every day. And we've reduced by more than 60 million clicks through basically debulking the inbox and through triaging work in what our chief of medicine respectively calls changing the funnel, where everything used to be filtered out before it went to the clinician, to the doc. Now it's going directly through the portals to the docs. We're trying to reverse the funnel and have everything triaged to the team so that work is done by top of licensed people. So you can make a difference. We have moved the needle ever so slightly in patient experience, in clinician experience, and in reducing burnout. There is no silver bullet. The board needs to pay attention to this. They have to assign accountability to the leadership team. You have to have meaningful plans to make change, otherwise nothing will happen. As I say, hint and hope is really not a great plan. And then I think you have to celebrate the successes when you've had them. So that's really my message from the front line, or from the C-suite of an organization that I believe is really on the front line of change. And I thank you all for your interest, and I know that together we will move the needle for this country.
So that's great. Thank you, Steve. And I'm sure it generated a lot of questions, but we're going to hold all of the questions till the end. So next I'll ask Cinda to share your thoughts.
So I want to go back to Beth's definition of compassion this morning, which was actually about recognizing suffering in ourselves and others and in our systems. And I think it would be a fair statement to say that our systems are suffering. And so what's the response to that? Steve, I think, has given us quite an important mandate about the importance of how we create the culture from the bedside to the boardroom. And I think what that means is that it's not an either-or proposition, that we are the culture. All of us who are part of this system create the culture. And so that means that all of us have a responsibility for shifting it. So thinking about how do we do that, and I think there really are many doorways. The doorway that I happen to pursue has to do with recognizing the real, to me, the root cause of burnout is the gap between what clinicians are actually doing and what they believe is right, which is fundamentally a moral question. And in that gap is where moral distress actually lives and thrives. It's where we recognize that we have obligations to our patients, to each other, to our organizations. And we know what we ought to do, but because of some kind of often systemic constraint, coupled with internal constraints. We heard about fear this morning, that sense of lack of belonging that get in the way of us actually doing what we know is right. And that creates a kind of moral residue where we are constantly carrying the unmet obligations that we have in our work into each of the encounters that we have, either with our teams or with patients and families. And we heard from Sue this morning about how that can begin to erode our ability to actually show up and to be with the suffering of the people we're called to serve. So we decided that one of the important elements that's often missing in culture change has to do with creating an ethical practice environment where people can actually practice with integrity. And that has to occur at the leadership level. But in the meantime, as we are trying to turn the ship around, what do we do and how do we begin to make change in the area where we all have influence, which is our own practice? So we've been implementing for the last 2.5 years the Mindful Ethical Practice and Resilience Academy for nurses at the front line. We have over 250 nurses who have been through this program. And the fundamental dimension of this, as you heard from our colleagues, Krasner and Ron Epstein, about the foundation of mindfulness. And it's interesting that in some ways the narrative about culture change is, oh, we don't need more mindfulness. That's just, sort of putting a Band-Aid on a broken, gaping wound. I would say that mindfulness is necessary for everyone at the bedside to the boardroom to be able to leverage their creativity, their innovation, their compassion to design solutions that are actually meaningful and sustainable. So that foundation of mindfulness is also necessary for us to be able to perceive the ethical problems, to name them, and to have the courage and the fearlessness to speak up and speak out about them. It is not about being complacent. It is actually being able to leverage the spine of integrity, to be able to speak from the place of our values, to call out the places in our system that are broken, that are actually undermining our ability to provide compassionate, quality, safe care. So this program is 24 hours of experiential learning. It is focused on reconnecting to why we're here, our sense of purpose, and how we can leverage that for culture change and change in terms of how we relate to our work on a daily basis. It focuses on communication. We go to the simulation lab and we simulate what it means to bring our voice into the conversation in a constructive, powerful way that is a reflection of who we really are and what we stand for. We have, in addition to that, created a community of practice, because one of the things that we know is that resilience is fostered by social networks and social support. And so what happens in this process is we typically have around 30 nurses at a time who participate, and they come in from representing all areas of our organization, not knowing each other. And very quickly, they begin to create a community. And through that community, it becomes a learning community. We also have retreats every year as an opportunity to come back together to reestablish those connections and reinforce what they have learned. So you're probably wondering, well, what difference does it make? Being a good researcher, we actually collected data, and what we found is we have statistically significant improvements in ethical confidence, competence, mindfulness, resilience, and work engagement, and decreases in depression, anger, and intent to leave. What we are seeing is that these individuals are becoming agents of change at the level of their units. And now we are leveraging them to create unit-based MEPRA champions who will be involved in providing support and guidance to their colleagues who are confronting ethical concerns, and to be involved in proactively identifying ethically challenging situations. So we're leveraging these skills as a way to spread change and awareness and skills that, instead of waiting until the ethical problem has become so intense that it's difficult to address, that we can be more proactive and learn some ways to manage the inevitable challenges that we're going to face, not to cover them over or to dismiss them, but rather to have some ways that we can actually be with the reality that we have as we are making the large-scale fundamental change that is needed in our healthcare system.
Great, thank you, Cindy. And lastly, Laura, please. Oh, I'm sorry, one more thing. I think in the spirit of this shameless self-promotion of books, you had something to share.
Forgot all about that. So related to this, we have been exploring the concept of moral resilience and how we can actually cultivate the conditions for integrity to be supported in ourselves and in our organizations. And so we have written about the individual as well as the systemic changes that are necessary, and we're happy to share those at the book signing.
Great, thank you. Laura.
I'm Laura Burke, and as Paul mentioned, I'm an emergency physician, and so I love my job. It's a really enjoyable job that I work firsthand with a caring, creative, hardworking team. But the emergency department, while impactful and rewarding, is also a bit of a chaotic environment where we see a lot of the failures of healthcare delivery in the public health systems become evident by patients who present to the emergency department. So I've seen the impact that that's had on emergency clinicians, nurses, physicians. So I've seen the anecdotes of what happens firsthand with burnout, as well as the climate that creates to clinician burnout. However, I'm also a health services researcher, and so while I hear the anecdotes, really thinking about this problem leads me to wonder, what's the data on this topic? What does the data tell us about the extent of the problem and what we can do to solve it? You've heard some of these statistics already. When you go to the data, you see that burnout is common. A recent survey shows that it's high as 76% of clinicians report having burnout symptoms at least some of the time. And this has major consequences for healthcare delivery in the United States. Of course, I care about my team and my coworkers, but it really has implications for patients in terms of reduced access to physicians. We know that it leads to reduced work hours and people leaving the profession altogether. And as Steve mentioned, just the cost of reduced work hours and attrition is $4.6 billion annually. And this has led to the growing recognition that if we're going to provide the triple aim, we need to have a quadruple aim, that we need to care for our clinicians to be able to provide safe, high quality, cost-effective care to our patients. So the data is clear. This is an epidemic problem. But as Steve mentioned, this is measurable and there are things we can do about it, and there's a growing body of literature looking into this. So I've been fortunate to work with a team of researchers at the Harvard School of Public Health and the Harvard Global Health Institute who paired up with the Massachusetts Medical Society and the Massachusetts Hospital Association to study this problem, to examine the literature, and to think about ways that we can address this problem on a broad scale with multiple stakeholders. So again, this is not, they didn't provide a comprehensive, complete way to address the problem, but a key framework to address it and a number of overarching principles that can help address this problem. So one of the key principles was that we should reframe the problem. Of course, it's important for individuals to address their own practice, but they really talked about, as we've seen the attention to this problem grow from really focus on the individual to focus on the system, the co-authors of this report note that we should reframe burnout from a personal failing to a systemic one. Like all public health problems, we need to look not just at the person, but at all the systems that are contributing. And a quote from the report that I particularly like is that this is akin to asking, basically putting the onus on the individual is akin to asking drivers to avoid car accidents without investing in repairing and improving hazardous roads. Simply asking physicians to work harder to manage their own burnout will not work. And that's not to say that the individual is not important, but they can't do it alone. So the key overarching strategies that the study authors recommend is, first and foremost, supporting mental health treatment for physicians. We know that the current historical way of addressing this problem can actually discourage clinicians from seeking help, because if you disclose a mental health condition, then that can lead to problems with obtaining medical licensure or clinical privileges. And so one might imagine that if you penalize clinicians for seeking help, that might actually lead them to avoid treatment and to actually hide the problem. Certainly an undesirable circumstance, which is likely to have it's not going to improve safety for patients if their clinicians aren't getting help for their behavioral health problems. So the Federation of State Medical Boards actually in 2016 called into question the practice of routinely asking probing questions about behavioral health conditions and asked state medical boards and other organizations to reconsider this approach. And to the extent that these questions are asked, they shouldn't focus on the presence of a condition, but similar to physical conditions, whether or not this is actually leading to impairment of medical practices. And so this is one way that state medical boards can encourage physicians and other clinicians to engage in treatment, and when they do disclose information, to make sure that that's treated with the utmost privacy and security. So in addition to encouraging help for clinicians, they also talk about improvements in EHRs. We've all heard a lot about the ways that a number of the key EHR vendors that are so common really add to the clinician work burden and take away from that time at the bedside doing the work that clinicians most care about and that they find rewarding. And so EHR vendors should be responsible, but so should the organizations that are responsible for overseeing them, that there should be key attention to usability and involvement in clinicians in every stage of this process to make sure that frontline providers are involved in design. There actually has also been recent work that shows that while EHR design and usability is an important contributor of burnout, other factors actually matter more. A paper published in JAMA Network Open just in the last month indicated that other work conditions, such as a chaotic work environment and lack of control over one's workload, actually had a greater explanatory power than the EHR factors. And for this reason, appointing an executive level chief wellness officer at every major healthcare organization is important. And Steve really outlined the way that this should work, and HRIS should be commended for having such a commitment to this issue, because this is a measurable problem. We know how to study it, and the chief wellness officer should have great seniority, should have the authority and the and should be tasked with measuring this problem and implementing the solutions to address it. And again, it's going to be unique at each institution. The strategies to help a multi-specialty outpatient physician practice is going to be different than a large multi-site emergency department practice spanning academic medical centers and small community EDs. You know, we're going to need to tailor our approaches to the challenges at each individual institution. The most important thing is to measure it, to figure out how to solve it, and for organizations to be held accountable for addressing this problem. The report lays out the key stakeholders. So it's not just individual healthcare organizations, but health plans, insurers, National Committee for Quality Insurance should make sure that there aren't a glut of quality measures that are redundant, that place burdens on providers and institutions. Of course, measuring healthcare quality is important, but a growing number of studies show that a lot of these measures don't really meaningfully correlate with outcomes or lead to improvement. We need to reduce the things that we're measuring that don't actually have impact on the quality of care provided. State and federal agencies, again, that oversee providers, but also health information technology, medical schools and residency programs. You know, there's attention to this, but we need a growing curriculum addressing burnout and what physicians can do. And I don't mean to focus only on physicians, because nursing burnout is, of course, just as important. And I think a lot of the challenges are similar, and so we should look at physicians and frontline clinicians across the board. So, again, anecdote is important. I witnessed firsthand the challenges that burnout provides, but as a health services researcher, there are clearly evidence-based approaches that have been used in the public health approach to multiple problems across the board to address this issue. And with the commitment of multiple stakeholders, we can use evidence to address this key public health problem. Thank you.
Great, thank you.
Thanks.
I'd like a round of applause for our presenters. Both for the quality of the presentations and the fact that everybody stayed within their time limits. It was so cool. We have lots of time now that we actually have close to 40 minutes to talk and ask questions. Just to start off, if anything struck any of you as you were listening to each other, things you'd want to bring forward or raise as a point?
So I have been part of the National Academies of Science, Medicine, and Engineering Committee on System Approaches to Clinician Wellbeing. And these are conversations that I think we're having in lots of different arenas. The measurement issue, I think, is an interesting one. It seems to me that if we only focus on burnout, that the absence of burnout does not imply well-being, and that we need to think about what else is missing in our measurement besides burnout as the problem. And I think there's a risk that if we only talk about burnout, in a way we keep reinforcing the sense of disempowerment and discouragement, and it provokes a fair amount of resentment by a lot of clinicians when now we're talking about burnout all the time. Oh, you must be burned out. And so I'm wondering, how do we expand our repertoire of measurement to include the alternative, which may be resilience, it may be well-being, so that we get a more complete picture of the whole experience, because it seems important, because we are hardwired toward the negative. Burnout just reinforces that sense of fear in our nervous system. Rather than celebrating the people, what is it about the people who are not burned out that we need to learn from? What is it that they are able to bring to their experience when they are placed in the very same circumstances that we don't yet understand? And can we begin to change the narrative about ourselves in an important way by also being able to hold up those examples of compassion, of when we have acted with integrity, when we actually have been able, in the midst of these chaotic, crazy experiences that we're in, to remain whole. So I think that's a challenge, and I think part of it is that we debate these things based on the research, when in fact we need to find ways that measure what is important to people and that will actually change the experience of our clinicians and the people that we serve in really fundamental and meaningful ways.
I love what you have said, and it really resonates a great deal with me. In truth, when we approached our strategic planning, we call this bucket of work joy, returning joy and meaning to the practice of medicine. When you're out in an audience like this, what people hear, the elevator segment, is burnout. Mm-hmm. But in truth, I think it is about the culture. And as we've approached this in an effort to really make change happen, we've come to the conclusion that the microenvironment is influenced by the leader and the culture. And this is, I think, what we heard from Amy Edmonston earlier today, creating the right environment to collaborate, work together, and form those resilient teams. It isn't at the foot, of the doc only. It's the team and how that team interacts. And there's more power in that teaming than perhaps anything else we do. I think there are, this is complicated. Who knew healthcare could be complicated? I do think this is complicated, and we definitely get the moral hazard part of this. At the same time, I just want to not forget to re-emphasize, as much as we ask people to own their own personal resilience, that so much of what we're asking people to do is not doable because we've made the work too hard. And if we don't force people like me and other CEOs to address that issue and spend money and resource, then it's going to be really, really hard to get to the place where we're ultimately going to feel good about the work that we're doing.
So I would say that our budget is the most important ethical document in an organization because it reflects what we care about. It reflects our values. And so until our budgets reflect the investment, I really agree with you that we are not likely to really make the kind of fundamental change that's needed.
Yeah. Staffing levels, work levels, support levels.
So I'd like to ask a question to the audience real quick on this budget issue, because I think that's key. How many people still type in, at your institution, do you have to type in your passwords? Raise your hands high if you have to do that. Okay. How many people are staying in this hotel? You got a little card, you touch the card to the door, it opens the door for you. That technology exists for you to not have to type 500 to 1,000 keystrokes per day of passwords only. If your institution hasn't invested the budget in that, you have to ask the question, are we really serious about addressing a root cause of burnout, which is this data entry burden? And it's that kind of thinking that we really need to pay attention to, because you're right, burnout is very pejorative on us as clinicians, but the problem isn't the clinician. It makes it sound like it when we use that term. The problem is the dysfunctional workplace where the work is undoable.
I made a joke to my colleagues that one of our sites, I work at a couple places, has a major EHR vendor. And I made a joke that having to log in again, because it waits a while to log out, is my punishment for actually sitting down and spending a long time talking to the patient. Because if I'm in and out, then I stay logged in. But sitting down and really spending a lot of time, then I get kicked out and then have to log into everything again.
So enough of us talking to each other. It's time. Let's. Do we have microphones handy to bring up? Find someone with a hand up, and let's fire away. We've got a few hands up in the front here.
Thank you. I'm from Toronto, Ontario, Canada. Our budget at our hospital is $0. So the big challenge is, how do we go about persuading C-suite to invest in physician wellness, resilience, positive physician experience? What is the persuasive argument when there's such resistance?
Yeah, can I try that?
Please.
Before I became the CEO of this organization, just contextually, I ran a 600-bed teaching hospital in New York, and I was the Chief Transformation Officer at Geisinger in Pennsylvania. And at Geisinger, what I was asked to do was to find $100 million of improvement, durable improvement. And it turns out that there is an extraordinary business case for investing in improving the systems that support the frontline providers by virtue of reducing turnover and reductions of FTEs. That's full-time equivalents. I'm speaking, medicalese here. And there's turnover in some circumstances that's as high as 20%. And that speaks to the work environment, the culture, and the leader of that organization. So I would say the leadership training would be an easy step. It's fairly inexpensive. If you look at the work that Mayo reported, that had an extraordinary, I don't remember the exact multiplier, but it had a multiplier effect. That is, in fact, what we have been working on, starting with an initial ring and then going deeper into the organization for leadership training. And then as it relates to systems, I would say that if you can get to the C-suite, then they are influential in changing the way work is designed. So there was a really cool article in the New England Journal about a year or so ago called "Gross, Get Rid of Stupid Stuff" inside the electronic medical record. There's virtually no cost to that, but your leadership could demand that clinicians, as you heard from Laura, clinicians participate in the design of work, which could then remove that stupid stuff. The other part, I would say that the simple fact of acknowledging a problem can begin to get problem solving started. So the way we went at this quality movement, probably in the 80s and 90s, was to recognize that it was a big problem, and then to start performance improvement initiatives directed at improvement. Now, ultimately, that got translated into a series of publicly reported measures and the like, but unless you start and shine a light on it and have the organization embrace that improvement needs to occur, it's going to be very hard to go forward. But I do think there are some straightforward, fairly low-cost things that could be done.
Others want to respond?
So the only thing I would say is we're hoping that
There's that hint and hope.
I'm
so sorry.
It's more than hope that the release of the National Academy's report will be a leverage point for people to use in their organizations. The evidence is reviewed, and a whole series of recommendations have been made, which I can't really tell you about yet, but that may be an opportunity to use that committee report as a way to engage your leadership in really looking at the issue as well.
This is a special audience. You can't tell them like one tidbit. They're very trustworthy.
Tone of silence, we're sort of,
Just
unfortunately, but.
Two other thoughts on that. One is the C-suite, and particularly the CFO, is worried about, they don't even like to think about burnout because they think there's two things we can do. We can reduce workload, which is probably going to mean reduced productivity and therefore revenue. And we have to spend money on wellness programs, which adds expense. And we're just trying to keep the doors open and the lights on with a very thin margin of somewhere between 1% to 5%. So presenting a proposal that actually can improve the bottom line rather than something that's only going to end up in additional expense is important, and thinking carefully about how to do that is key. To get empathy from the C-suite, the simplest thing to do is to invite them to shadow clinicians while they're working, because so many C-suite folks are so separated from the reality of the work that they just read reports and see spreadsheets. They don't know what's actually happening, and to come and actually observe all the frustrations and challenges you deal with can help them think about this in a very different way. So if you're a C-suite leader, I tell people go shadow a clinician. If you're a clinician, find a C-suite leader who might trust you and have them come and shadow you to really create a dialogue and create much more empathy between the frontline and the C-suite.
I'll just get one last tidbit. When I went to Geisinger, one of the things I learned that was really quite counterintuitive is that sometimes spending money is much more powerful than not. And investing, I'll use a story that's not a Geisinger story, but when I was running a hospital in New York, we had hospitalists, and the rate of turnover in the hospitalists was extraordinarily high. I can't even tell you. But we made the commitment to invest in an additional shift of physicians, which was quite significant. And you know what wound up happening? We virtually stopped the turnover in the hospitalists. We saved a lot of money in recruiters and in all the transport, the relocation costs. So sometimes spending a little bit of money on the faith that it's the right thing to do, the morally appropriate thing to do, can often save you money on the back end.
Great. Next. Well, very briefly, we've all monopolized.
In our Canadian market, it's actually good news for a hospital when doctors leave.
Oh,
because
no.
they don't pay us, they don't have to recruit us, and then now their budget can work because there's less resources being used. So it's kind of a bit of a reverse situation that we're
But your patients.
But yeah, so quality of care is probably our main argument. That we can.
Now, doctors are expensive, so who needs doctors? If without doctors, you shouldn't need a hospital. Next.
Nurses.
So thank you for the discussion. This is really enlightening. I've got a quick comment and then a quick question. The quick comment is this idea of burnout is kind of like the end stage. And so I liked this discussion about, pre-diabetes, pre-burnout, and then really trying to identify that and nip at that.
Right.
So comment. Question is, I think most of us here are drinking the Kool-Aid about resilience. And I've tried to implement that as well in my institution. And the question that I have is, when I do that, and when we all do that, they all come back to us and say, well, what about efficiency of practice? You're telling us just, this is all on you. You just kind of figure it out yourselves. And how do we as non-CEOs who don't have as much control over the practice environment try to convince our staff, this is going to be helpful?
I don't know the answer because I think it varies from place to place, but I think if you recognize that the workflow is the ultimate arbiter of the efficiency of your organization, and if you begin to study the workflow from a process perspective, that what you need to get to is what's referred to, forgive the jargon, of high reliability. And when you take that journey, which is effectively a lean journey, you eliminate waste. So the trade is you, organizational leadership, join us on the journey to excellence, to process reliability and high reliability, and then we'll join you from a resilience perspective. So they're not mutually exclusive. I actually think that the practice efficiency is far more powerful and you have a lot more leverage there because a small change can impact so much. But the argument is most people will get, there's waste in the system, the numbers that are thrown out are 40%, and help us get rid of the waste.
So could I just add one more thing to that? I think one of the things that frontline clinicians can really help with organizationally is being able to articulate and recognize the patterns that create the problems in the first place. We're pattern detectors all the time. And if we can focus in on, I'll use my ethics issues as an example. If we can actually articulate what are the conditions that cause us to have this ethical problem in the first place. Sometimes it's throughput, sometimes it's lack of resources, that our patients don't have the resources that they need for a safe discharge. Sometimes it's because we have patterns in our system that undermine continuity of care. So every week there's a new plan of care for the patient. Those are patterns that once we can detect them, then we can say, okay, this is what needs to change. And we can bring solutions into the conversation rather than just saying it's a staffing problem. Because I think that kind of a claim can be heard as, people are just whining and, it gets dismissed. Whereas if we could say the reason that staffing is important is because I am not able to fulfill my obligations to my patients and I'm actually causing harm. And these are the patterns that have contributed to that situation, and this is something we can do something about.
I think people will be more receptive to the emphasis on the individual if there's the concurrent system-wide efforts to improve practice. And they're both important, but telling people to take a class when they don't have any time to do their job is hard.
Great. Other question?
I love the idea of the question, what are we not measuring? And I would say probably we're not measuring what we're not seeing. And one thing we don't see is, and probably can't see, is the capacity to care. But for me, just to put it simply, compassion is caring. I know that's kind of a trite thing, but the spiritual care, the medical care, the nursing care, that's like the compassion all around us. And I think if we designed our medical and healthcare systems around that question, is this about caring? What is this about caring? What are we trying to achieve with this system in order to care? I mean, I think that might be a principle for organizing a system that doesn't burn people out.
I think what you're pointing to is really important because it's going beyond having our values on a plaque on the wall versus actually embodying them and living them and using them as the anchor for how we make decisions at every level of our organization. And I think that is, we like to talk a lot about our values, but it's actually much more difficult to actually live them. And that's what's missing, I think, in a lot of our design work and also in our culture change, is the connection to how will we actually embody these values.
What I really loved about this morning, Beth Lowndes' comment that compassion is really a verb, and I'm not sure we all get that. It means that you're going to do something for other people. Mm-hmm. So if you take that back, I think that, and can try and get that into your mission and vision and value statements, I think that implies we will do something positive.
Other questions?
Yes, Cindy, you mentioned that burnout comes from when clinicians can't do what they think is right. And so I was wondering your thoughts on, it kind of fell into two buckets for me. So I'm a respiratory therapist at a large urban medical center. And so sometimes patients come in and their wishes are different from what I think I would want if I was in their situation. So it's difficult sometimes to continually treat those critically ill patients. It also falls into a different bucket where there's disagreement among team members. So, perhaps a physician thinks that we should kind of press on and, do more therapy, more surgery, and my opinion and what I feel is right is not. And so how do you kind of manage getting everyone on the same page?
It's a great question, and I think it speaks to part of what we heard this morning about we need to have spaces, moral spaces, where we have psychological safety, where it is actually safe and expected norm that when people have those kinds of concerns, they can bring them up without retribution or being disrespected or shut down. To me, that's that culture of ethical practice. And part of it is that we have to normalize these conversations. Instead of making them a big event, ethics is part of everything that we do. And so being able to have regular, normalized conversations. So one of the things we're about to implement is a proactive identification of cases, of situations where there are likely to be ethical challenges. So sometimes it has to do with length of stay, it has to do with patient characteristics in terms of particular diagnoses, sometimes it's family characteristics, sometimes it's characteristics of the team. Are there certain disciplines or specialties where there tend to be more ethical challenges? Are there other factors that should be red flags that if we noticed them and we paused and had an opportunity to talk together about our concerns, that we may avoid some of those intractable conflicts? It also means that we have to be have systems in place where we can identify those patterns. So one of the patterns in our organization is lack of continuity in terms of plan of care, documentation of patient preferences. So those are sort of system issues. Having opportunities, for example, to do ethics rounds where routinely we pause and we identify troubling cases and we come together with a set of norms and facilitated conversation where we can actually hear and understand each other's perspectives and potentially learn from each other. I also think that there are ways in which we have to also recognize how our biases are showing up in our work, and the distinction between my personal preferences and my professional role. And how do I make sense of that dissonance that occurs sometimes is where, individually and collectively, I think we have to create space where we can acknowledge that that is part of our work. And perhaps to reframe conflict not as failure, but as a part of a healthy community where we can learn how to disagree and see different perspectives in a respectful way.
I think some of that speaks to just having a team that knows each other, works well together, and respects each other. So, in the emergency department, if there's a complicated or difficult case, it will often involve just the team reviewing the plan so that you can execute that plan. And that often gives the other team members that space to express their concerns or questions. And if it's somebody that you've worked with for a while and established a relationship, you don't see it as threatening when they question you. It's you're working through it together to make sure that you can complete the plan and, identify any particular problems that might arise.
Great, thanks. Next.
So I have a question for Cinda about the 24-hour training program that you offer that creates some agents of change. And I wondered if you could talk about, how that got sponsored to actually allow nurses to have 24 hours of training, and second of all, just describe the program a little bit that had measurable outcomes.
So the reason this got started was because our dean was very concerned that some of our graduates were leaving their jobs after just a year. And so she said, what can we do about this? So we created this program that was initially funded by philanthropy and then continued to be funded through an ongoing source of funding through the hospital. The program is a voluntary program, and one of the things we learned in this is that you really don't want people to be voluntold. You really want them to come when they are ready and when it serves them well. We started out by focusing on nurses with 1 year of experience and their preceptor, and eventually we just opened it up to everybody. So we had a range of brand new nurses and nurses with 40 years of experience. The combination of those were fantastic because they both learned from each other. The program is very much experiential, and it really reflects an orientation toward, change is an inside-out process, and providing a space where people came together, often really feeling depleted and discouraged about their work, and finding that they were able, through the development of mindfulness practices as well as very specific skills in ethical competence, communication, resilience, they were able to reorient their work in a way that they were able to really see the areas where they had control and areas where they did not have control of the environment, and to empower them to begin to make change in how they practice themselves and how they could be an agent of change at the unit just by how they showed up, the questions they asked, how they communicated, and how they actually conducted themselves. And that has been really powerful in terms of almost contagion, because it does matter how we show up. And to feel that you start out not seeing yourself as belonging in the conversation, to seeing yourself as absolutely empowered and obligated to speak up about things that are not working, and having the skills to do that and feeling capable and confident in how to actually do that was reinforced by simulation. So we went to the sim lab. We had trained actors who portrayed common interactions with other clinicians where they practiced self-regulation, communication, and at the end of it, were able to see that they could actually be successful. Some of them talked about the program as being, we are all resilient. As Mick said, we are all resilient. Sometimes we just need additional tools and skills to remember that. And so that has been a real force in terms of numbers of ethics consults that have been requested, the ways in which they have utilized other resources in the organization, the way that they are beginning to be instigators of new conversations with physician colleagues and with patients and families to address some of the issues that are really causing them to be awake at night and unable to really find a place of integrity in their work.
Great, thank you. Other questions? Got it.
I appreciate your work. It sounds very similar to the work I'm doing in my program, Map It, that I have a poster on it for, but I also got the award for last night, which was a tremendous honor considering what's going on in this conference. I keep saying I feel like an imposter sometimes, but that's my own psychiatric evaluation. But I do my work interprofessionally, and I'm getting the sense of what you're describing is nurses only, if I'm not mistaken.
Yeah.
And one of the assets of my program has been the comments over and over about we all have the same issues, and being in these groups where you're creating community. That's what you're doing. You're creating a community that just doesn't have space in another time of the day. So that whole idea of community creating and engagement and bringing more of meaning back to work that's talked about in the literature is what you're doing and what I'm doing. But I do mine interprofessionally, so I didn't know if you had any thoughts against interprofessional.
Not at all. I absolutely agree that interprofessional is the way to go. What I've noticed in nursing is that it's important for nurses to be able to engage in that process from a place where they feel confident about their ability to be in the interprofessional dialogue. And so we began with nursing because that was, they're the largest group of healthcare professionals, 4 million nurses in this country. And that it was important to begin where that pain point was in our organization. We'd love to be able to extend that.
I began with nurses too, because we have a large, powerful nursing force, so I agree with you. But I did it with physicians initially, and I had co-leaders of my groups, so there was a physician and a nurse co-leading, because otherwise the power hierarchy wouldn't be right. And then I had this idea to include chaplains and social workers, the whole entourage. I haven't had much CODA leadership from the other groups, but I've had it continually from nursing and physicians. So I want to emphasize, if you do interprofessional work, the leadership has to be together in that area, because it can't just be from one profession.
Yeah.
So I commend you on your work, and I think building community is the power of what we're trying to do, and space for that community to develop.
Mm-hmm.
Yeah, that makes perfect sense. One of the 6 drivers of burnout, according to Maslow, is breakdown of community. And we've seen it happen in so many ways. And so that's very powerful to help address burnout. We've got a question here.
I just had a quick question as a follow-up to the C-suite discussion that was happening earlier about the financial incentives and making the business argument. I just wondered if anybody had a reference to recommend, if you do catch the ear of your leadership. You said there's a strong business argument to be made that this financially is what makes sense, that putting money into these things returns money. Is there a quick reference?
The easiest place to go to, because there's a calculator, an online calculator, is the AMA website.
Okay.
And the reference, I believe, is from April or the Annals of Internal Medicine.
Okay.
And I'm going to have to think about the lead author. It might be Friedman. But these are the kind of context of when you lose one physician, what does it cost? And the AMA's online calculator will allow you to calculate that.
And I'm waiting for someone to do that, a study in nursing, because I think that those data would be incredibly helpful. When you think about, for example, how many people a nurse touches in the course of a shift, it's pretty incredible to think about what that means in terms of both opportunity lost and replacement costs. And we need to have both of those numbers to be able to really make that financial case. So I don't know who those wonderful researchers are.
It's worth mentioning that there is an extraordinary nursing shortage.
Yes, there is.
And those organizations that respect and support nursing so that there are higher retention rates are going to have a competitive advantage. So just from that financial perspective, I think the turnover cost is about 3 to 1. It costs you about 1/3 of the cost of the salary to recruit another nurse, let alone the overtime and other incremental expenses associated with recruitment.
Yeah. And just really specifically on the AMA website, it's called Steps Forward. So if you search on Steps Forward, you'll find those. I think we have time for one more question.
I have to say, I have a microphone, so
Who's got the microphone? Okay.
Leading on to the question about continuity, it seems like we are running headlong into burnout because of the way that our clinicians are doing 1-week rotations and our nurses are doing 12-hour shifts. And even though they're saying they're doing it for their survival, they are burning out because they're doing it, and there is no continuity and there is no community. I'd love to hear your thoughts about that.
There's
I think you're raising a really important point, and there's a lot of discussion going on now in the nursing community about how do we think about that. We have data now that suggests that there are health risks for working 12 hours a day, because we don't just work 12 hours, we work 14 and more. So I think, it has undermined community, because back in the day, when some of us were young clinicians, we knew each other as people because we were together. Now we don't even have to see each other to talk about plans of care or to write orders. It's all done electronically. So this piece of, I think we have a relationally depleted healthcare system that is showing up in how we actually do our work. We don't know each other, we don't know our patients. And because of that, I think it makes it very difficult for us to feel like we belong and a part of a community. And so I think those are things that also from a system perspective, what can we do to restore our sense of connection to each other?
It would be hard not to mention Schwartz rounds. Right,
Yeah.
as an opportunity to bring people together. And actually, Mayo studied facilitated dinners They originally studied looking at having a specific few topics, and actually when they no longer facilitated it with a third party, just getting people together made an enormous impact as well. So just that.
So I'd like to just wrap up real briefly, a minute or two of thoughts from each of the panelists now that we've had our discussion. And
well, I'll leave you with the notion that you've got to get the leadership bought in, and it is a journey, but it won't happen unless you have the leadership to commit the resources in order to make change happen.
Great. Cinda.
I think what I would say is that we need to find the way to harness our commitment and our passion so that we can connect that at the front line with the bottom line at the C-suite, and leverage that shared commitment for really fundamental and sustainable change in our healthcare system.
I would say that we need to engage at all levels, and of course it's important at the individual and organizational level, but even at the federal level when maintaining oversight of quality measurement and electronic healthcare records, that there should be multiple levels of attention to this issue, and that there should be resources to study it and show which approaches are most effective at a broad scale.
Great. Well, once again, I'd like to thank the panel and thank all of you for your participation.
Thank you.
Great.